Hi, everybody. Welcome to the Basics of Coordinated Specialty Care for Early Psychosis webinar series. As we're just about to get started, please go ahead and introduce yourself in the chat. Let us know where you're tuning in from, and we will tell you a little bit about the series.
All right, hi everyone. This is Lola Nedich, the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box. Now I just want to review a few housekeeping items before we begin. Next slide, please. Thank you. All right, participant microphones have been muted at entry. You will be able to unmute them during the discussion portion of the presentation. During the presentation, if you have any questions or technical difficulties, please use the chat box. This webinar is being recorded and will later be available for viewing on the Mhtdc website. To reach us after the webinar, you can email newengland@mhtdcnetwork.org. Next slide, please. So this slide provides a description of our disclaimers for Mhtdc. Next slide, please. The Mhtdc network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. Next slide, please.
All right, so thank you, Lola, for the introduction. And I'm going to tell you a little bit about the Coordinated Specialty Care Basics webinar series that we've been running. This is the 6th of a 7-part monthly series that is co-sponsored by the, I keep losing my place where I can see stuff. It's co-sponsored by the Mhtdc of New England, as well as the National Early Psychosis Working Group, and some partners from across the country that represent 10 regional centers, 2 national centers of the Mhtdc network. And I just want to start by thanking you all for choosing to spend some of your afternoon with us, or depending on where you're tuning in the country, it could be morning or night or whenever it is. I know that there are lots of demands for your time, and really appreciate getting to see so many of you. It's also especially a treat, those of you who have your cameras on and we get to see your faces, and even if you're eating or doing different things, it's just really nice to be able to see you and see who we're talking to. The goal of this series has been to provide a brief introduction to what coordinated specialty care for early psychosis is all about. The series is geared towards any individuals that are new to working on an early psychosis specialty team. This can be students, clinicians, prescribers, supported employment specialists, family clinicians, peer specialists, or if you've been working on the team for a while and just interested in learning more. Really, the goal of this series is to cover a lot of the basics, especially for somebody who's new, so that it's a little bit easier to kind of learn about what your role is going to be and what the roles of some of your colleagues are on the team. And each of our seminars has been co-presented by professionals with expertise in that component of care, as well as individuals with expertise that comes from their lived experience, who speak to this aspect of care and how it's been meaningful in their journey towards recovery, and also share some of the wisdom that comes from lived experience with new professionals. The content of these webinars is recorded, and we are going to be using it for the development of an open source and freely available online course that we hope will be helpful in orienting new staff and trainees that are beginning to work in a coordinated specialty care program for individuals experiencing early psychosis. So today's session will be presenting an overview on medication management. We have three fantastic presenters. I'm especially excited about today's session because our presenters are folks that I have gotten to know well, who come from our team at Beth Israel Deaconess Medical Center in Massachusetts. And I am really happy to kind of turn things over to Dr. Keshavan, Nathan Shrerian, and Charles Stromer to introduce themselves and tell us a little bit more.
Thank you, Michelle, and good afternoon, everyone. It's my pleasure to introduce our team of presenters, including myself. I'm Mhtdc Keshavan. I'm a psychiatrist. I'm a professor at the Harvard Medical School, and also I'm the academic head of the Department of Psychiatry at Beth Israel Deaconess Medical Center. I have worked for over 30 years in taking care of, as well as doing research on serious mental illness like schizophrenia, and in particular, those in the early phases of this illness. And Michelle mentioned coordinated specialty care. This is a kind of a concept that is emerging that to be effective, the management of early course psychosis is best done in a team-based fashion with multiple disciplines coming together and coordinating care. So I'm joined today by two remarkable individuals, both of whom we have worked together in the last many years. One is Charles Stromer. He will introduce himself, and Nate Shrerian. Charles, do you want to go first?
Sure, I'm Charles, and I work in finance and technology, but I've also co-authored or authored 3 psychiatry papers that were published and advised on 2 more that were published. And I'm a member of the Consumer Advisory Board at Beth Israel Deaconess Medical Center, and I have lived experience with schizoaffective disorder.
Thank you, Charles. Nate?
Hi, I'm Nate Schwarian. I work with Tuneflurry Music, which is musicians and mental health recovery. I've been a member of the Consumer Advisory Board for many years now. It's going to be probably over 10 years. I've been living with a diagnosis for probably over 15 years now. I also have an associate's in biotechnology, and yes, that's it. I've done with the advisory board, Consumer Advisory Board, I've done some mental health research.
Thank you, Nate. Now, this is a unique, educational experience for all of us, and hopefully to all of you, because it brings together individuals who provide care, such as myself, and those who experience care and have a lived experience of the illness, such as Nate and Charles. So the way we wanted to structure this is, first, we want to get the experience of Charles and Nate on different aspects of medication treatment of psychosis. And then I will summarize briefly what the literature tells us as to best practices. And then we will open the floor for discussion from all of you before we wrap up. So if we have the next slide that has the first question. So the first question to both Charles and Nate is, what is the most important that you think for new providers should know about management of psychosis? So Nate, do you want to go first?
Yeah, I mean, I guess I'd like to say that if it would be good to attempt treating it without antipsychotic medication if possible. But if antipsychotic medication is necessary, I would say use as low a dose of it as possible, because the side effects from these things can be really terrible. From the antipsychotic medication can be really a struggle. So I would say try to use minimal doses of antipsychotic medication. And I guess I'll also put in there that those side effects that are caused by the antipsychotic medication, those can be treated with antidepressants like dopamine and norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors, and actually benzodiazepines. All three of those can help with the side effects of the antipsychotic medication.
Thank you, Nate. It's important that you brought up side effects at the very beginning. We will be spending a little bit more time on that issue down the
It's
road.
been a huge issue in my treatment.
I will come back to you for
Okay.
more
Yep.
of a discussion on that. Charles, do you want to add anything to this question? What should
Yes.
providers know?
What's most important is to realize some of your patients may have trouble with medication adherence, which can lead to rehospitalization if there's a problem.
Yep.
And that's something I have to be really cognizant of, because I help take care of my elderly parents. And I have to take my father to go get surgery soon at a hospital. So I have to do whatever I can to not be an inpatient, because the BA.5 Omicron variant is spreading rapidly. Yeah, and another thing is, even if you deal effectively with positive symptoms, there may be negative or cognitive symptoms that should be addressed for quality of life.
Yep.
And regarding what Nate said, I take an SNRI, which boosts norepinephrine, and that helps treat anxiety and depression, but also boosts cognition a little. And I take Abilify and an atypical it's an atypical psychostimulant called Nuvigil. And they both are thought to boost dopamine a little in the prefrontal cortex. So that helps some with cognition.
Great. Thank you for bringing that up. So it is not just psychosis, but very importantly, negative and cognitive and mood-related symptoms as well that we need to be addressing. If you go to the next question, Shala, what have your previous prescribers done that did not work well for you? Charles, you want to go first on this?
Sure, not spending enough time to get the diagnosis correct. Initially, I was self-diagnosed with depression and OCD, but then later was bipolar with psychosis. But I kept having unwanted intrusive thoughts regardless of mood changes. And also I would have social cognitive difficulties that were atypical of bipolar disorder, more like schizophrenic. So getting the correct diagnosis is really important to try to optimize the meds.
Well, that's such an important thing that you bring up. And I have a little bit to say on that. But before I say it, Nate, do you want to add anything to that point?
I think that's something that I've experienced that didn't work well, although it did bring me back from symptoms, was in the hospital, just being prescribed so many medications, so many, just kind of, they're trying to treat my symptoms by, handfuls of antipsychotic medications. And I've been resistant to that because the side effects they hurt in various ways, and the side effects are a problem. So really being just given large doses of antipsychotic medications when in the hospital, I feel like is not, what winds up happening is outside of the hospital, the doctor I had afterward, it seems like I work more with that doctor on more of a dose that I can stay on and medications to help.
Yeah, you bring up an extremely important point in that medication management does not stop at the inpatient once you're discharged. Often when an individual is in a hospital for an acute episode, the tendency for the prescribers is to use lots of medicines and large doses and so forth. That may help in the short run, but in the longer run, to move back towards recovery, there is a lot of work that needs to be done by the prescribers in collaboration with the individuals with the illness to, move towards, say, maintenance dose that is the best to prevent relapse, but at the same time, comfortable without side effects. But on to the point that Charles made, which is very important, that not spending enough time with the doctors is a big issue that doesn't work well. So I'll give you one example. There is this, unfortunately, with managed care in the last decade or so, there has been this tendency for the so-called 15-minute med checks. Psychiatrists and other prescribers simply see patients for 15 minutes and that's it. And while they can renew the prescription and write a script and write a note and do some basic checks, important things get missed out. I'll give you one example. Just a couple of weeks ago, I saw a young lady for a 15-minute med check. And on that day, I had a little bit extra time. And so I kind of leaned back and just asked her to tell me more as to how things are going on in her life. And we chatted for half an hour. And in that, very slowly, she came out with the point that she's having low energy and she's not having as much interest in life. And especially she's not as interested in intimacy with her partner. And then that made me explore a little bit further. And it turned out then, in a few minutes, she admitted to having some tenderness in her breast and some milk secretion. And that led me to ask the question, was there, do you have any problems with your periods? And she said, lo and behold, her periods have been irregular. So that made me think that maybe her prolactin levels are too high, which can happen with the medicine she was taking, namely risperidone.
That can happen to guys too.
Oh, it can happen to guys. You're absolutely right.
Yes.
Now, the point is, if I was just finishing with the 15-minute med checks, I would never have been able to find out all this, which is so important for psychopharmacology. And the lesson here is that prescribers are often, taught to just do their magic in 15 minutes and get on with the next patient and so on. That's a terrible idea. And prescribers don't do just one thing. They have to get to know the patient. They have to develop a relationship. They have to develop an alliance. They have to understand everything that is going on in order to do the prescribing job itself well. So prescribing always comes with some psychotherapy and some alliance building, some collaboration. And that's, of course, we'll talk more about the shared decision-making part as well. So if you go to the next slide. Now we talked about what did not work. The question to both of you is, what is it that your previous prescribers have done that was helpful? So Nate, you want to go first on this?
Yeah, okay. I think after being in the hospital, like coming out, the prescriber, I feel like at that point, there was more of an effort to, like you were saying, maintenance dose to try to get to that. I feel like that has been the situation where I've done more work that's kind of adjusting to having to take the medication for a long time. And so I think the effort there has been to have the antipsychotic be about the minimal dose that it can be, to reduce the side effects. And then in addition to that, they prescribe other medications, some antidepressants. For a little while, I was on actually a medication that Charles mentioned, modafinil, but my insurance stopped covering that, so I've been taking that. I felt really pretty strange sometimes on the medication, and to deal with that, to help with that, my doctor has prescribed benzodiazepines, so I now sometimes take Ativan, and I used to take clonazepam. But I guess regarding antipsychotic medications, I would say using the minimal possible dose that's effective, and then using other things to help treat what's remaining, whether that's symptoms or side effects. It could be symptoms of depression, or it could be side effects of depression. Either way, antidepressants could help. And I guess recently, actually, I was having trouble, and the antidepressants weren't doing enough. So I actually went into the hospital and started getting electroconvulsive therapy, ECT. So I've been getting that 2 or 3 times a week for I'm not sure how many weeks now, but it's been helpful. I've felt better than I did before that. So that's another.
Thank you for bringing that up, Nate.
Yep.
ECT can be remarkably effective in some situations, and unfortunately, there is a lot of unnecessary fear and stigma attached to ECT, and
Yeah, I mean, there are, like in movies, like One Flew Over the Cuckoo's Nest, and it looks like it's a horrible thing, but it's really actually not bad. I mean, they go in, let's see. Yeah, I mean, actually, my memory's not.
Okay, we can come back to this. Yeah.
Okay.
Yeah. Thank you, Nate. Those are very, very helpful points. Charles, do you want to add anything?
Yeah, 2 things they did that were helpful: letting me time my meds to my circadian rhythm.
Yeah. Okay.
Because I can't sleep well at night unless I take Abilify.
Yeah.
And Nuvigil, the atypical psychostimulant, is stimulating, so I take it in the morning. And this all helps a lot. And another thing that helped is the psychiatrist thought I might do better on Abilify when I was on olanzapine or Zyprexa.
Mm-hmm.
And so I enrolled in a clinical trial at MGH in 2008. And they augmented the Zyprexa with Abilify, and I was able to switch over eventually. Now, normally taking more than one antipsychotic at a time isn't recommended, but this was a titration kind of study, so it worked well.
Wonderful. Yeah. So there are always, creative, alternative approaches to treatment. One could be keep an open mind, and they could be helpful. Is the main point you're making. Last question, or maybe there's one more. What are your thoughts about shared decision making with your prescriber? Charles, maybe you can say about the shared decision making idea. Any example from your side?
Yeah, an example would be that I have only one side effect that I'm aware of, which is a tremor in my left ring finger. And so I asked if we could minimize the Abilify a little by the bare minimum, going from 20 to 15 milligrams to see if the tremor would go away. And it didn't entirely, but I started feeling more anxious and depressed on the one hand and more spacey and like a robot on the other.
Mm.
And so I went back up to my 20 milligrams, which is the maximum dose. And I'm fine, except the tremors are irrelevant compared to how I feel in that respect with positive and negative symptoms. But generally, I agree with Nate, like start with the minimal dose and work your way up. I didn't get to 20 milligrams immediately. We worked our way up from 10 milligrams until my intrusive thoughts went away.
That's a great example. So you kind of discovered it yourself as to what's the right dose for you.
Yeah, I mean, either I have trouble sleeping or intrusive thoughts or negative and positive symptoms, or I don't, and I don't want them.
Yeah. Did your doctor work with you? Was the doctor collaborating in terms of finding the right medicine and the right dose for you?
Yes, and another benefit of Abilify for me is it acts as a mood stabilizer.
Yeah.
In addition to being an antipsychotic, and it also augments antidepressant efficacy.
Yeah, and that brings a question in my mind when individuals are offered a treatment with an antipsychotic. Often their immediate response is, I don't want an antipsychotic, I don't have psychosis. But at the same time, these medicines don't just do one thing. They help psychosis, but they also help mood stability. So by using these names like antipsychotic and mood stabilizers, we are kind of creating a problem. These are broad spectrum medicines. They work on multiple things. It may be better, as I think about it, to use terms like, a dopamine antagonist or a dopamine partial agonist or a serotonin antagonist and so forth, instead of saying this is an antipsychotic, which can have a little bit of a problem. But this is just my thought. But Nate, do you have any comments on?
Well, one comment there. I mean, I sort of think that the antipsychotics they don't specifically enough treat what the problem is, I think. I mean, I think they treat the problem and they cause a lot of other problems too.
Right, that's right.
I mean, I guess shared decision making with the prescriber. It's good to work with the prescriber to, okay, like say you get out of the hospital on a medication that was, it's treating symptoms, but it's maybe it's causing a lot of side effects. I think working with the prescriber, then it's important to work with the prescriber to find one that causes less of a problem.
Yeah.
And hopefully find a lower dose of that. And again, other medications possibly to possibly help deal with some of the side effects.
Yeah, thank you. I think what both of you are really teaching us is that on the one hand, we, the prescribers, might have the expertise in the treatment of the illness with medications and so forth. But you are the experts in your illness. How a given medicine works or does not work for you, nobody can know it better than yourself. So we, the prescribers, have to understand that. And this has got to be collaboration between those who know the illness and those who know their illness. That is basically what is shared decision making. We'll talk more about that. Let's go to the last question. Is there anything else about your recovery journey that you would like to share in order to teach new providers about how to promote recovery?
I think it's good to think of it as sort of a balance. I mean, someone might have symptoms of psychosis and then get treated with an antipsychotic. But it's good to use as low a dose of that as possible. And so that's part of the balance. And then also, it might be pretty important to prescribe other medications to help deal with the side effects. So it really, I think for some people, is really a balance of symptoms versus side effects. It's important to treat the symptoms, but if the side effects are not possible to tolerate, then that's a problem that has to be addressed somehow. Right now, I sort of feel like they don't. I feel like more types of antipsychotic medication are needed.
Yeah.
All of them block dopamine, and they have similar mechanisms. I feel like that new types are needed, but yeah, I think it's important to balance the symptoms with the side effects, and try to keep the side effects minimal.
Yeah, thank you. Charles?
For me, the most important thing for recovery is to remain medication adherent, so I don't have a setback like an antipsychotic, like a psychotic relapse or having to go back to the hospital.
Yep.
And to Nate's point, to offer a glimmer of hope, Synovian and Karuna Therapeutics have non-dopaminergic antipsychotics in the works, but they're not yet FDA approved.
Yeah, I'm definitely interested in those. I wish they were. Do you know how long that would take?
They have to do a phase 3 study. That can take quite a while.
Oh.
Yeah.
Oh.
Yeah, thanks for bringing that up, both of you. So this is where research is so important. We still have a lot of unmet needs in the psychopharmacology of serious mental illness. We have covered all of those. While the medications that we now have do help with psychosis, we do not have medications that can help cognitive impairment. We do not have medications that can help negative symptoms and so forth. We do have medicines that can help with depression and anxiety. So as Charles said, there are some new ideas in the pipeline that work outside of dopamine, but it'll take another, maybe a couple of years to see something coming into the market.
Phase 3 is pretty far along, right?
Well, nowadays, this time from idea to new medicine has been increasingly shortened. It used to take 17 years to get a medicine from phase 1 to phase 4. Nowadays, it's like less than 5 years. So there is progress. That's what I would say.
That's good.
So thank you both for addressing these questions. So let me quickly summarize what we know from the literature as to what are the basic principles of psychopharmacology in the management of individuals with serious mental illness. And in fact, many of the points that I'm going to say, you have already brought up in one way or the other. And all I'm going to do is to summarize them over the next 10 minutes. So this is a slide from Delbert Robinson, who looked at all the problems in prescribing practices in the management of early course psychotic disorders. And there are all kinds of problems that one sees, including using too high a dose For example, just today I learned about a patient who was on 40 milligrams twice a day for olanzapine, which is really not necessary. This was a patient just discharged from the hospital. Now we have to kind of slowly but definitely move towards a maintenance dose of 20 to 30 milligrams. And quite often patients are on antidepressants or even anti-Parkinson drugs, even though there may not be a need. The more the number of medicines, the more side effects. So this is called polypharmacy, and that should be avoided. And as Charles pointed out, multiple antipsychotics are not generally recommended, but there are some situations where two antipsychotics, if used correctly as complement to each other, could be helpful. Like someone who is on Zyprexa could benefit from a little dose of Abilify, but not everybody. But some individuals it might work well. Then there are situations where there are too many other medicines that are used, but not an antipsychotic. And that could be a problem in individuals with psychotic illnesses. If you're only on an antidepressant, but not an antipsychotic, the chances of a psychosis might go up, for example. Again, the high dose of antipsychotics is a problem, and using stimulants without an antipsychotic can be a problem because stimulants can trigger psychosis as well. So let's go to the next slide. So I summarized the 10 principles of good prescribing in these 10 C's. And so we already talked about the first one of those, which is coordinated treatment plan or coordinated specialty care. We'll talk about that in a moment. Connecting between the patient and the prescriber would be very, very important. Of course, having a treatment plan which the patient consents to is very important. Assessment comprehensively. Charles brought up the importance of accurate diagnosis. We'll talk about that. The right choice of the medicines, the right dose, and the right duration. And Charles also brought up the importance of compliance, even though the word compliance is not as good. Sometimes people use the word adherence. That's also not great. Or treatment alliance could be another option. But the point, you get the point. In order to stay well, one needs to stay on the medicine in a maintenance dose often. Collaborative decision-making or shared decision-making, we'll talk about that. Minimizing comorbidity, that's very, very important. And checking and preventing side effects. And whenever in doubt, getting another opinion. So these are the 10 C principles, if you will, that would come in handy. Now, what is coordinated specialty care? So basically, coordinated care is nothing but good teamwork. So, a good psychopharmacological practice would require not just prescribing in those 15 minutes, but you would need to have a team where, for example, you would want to talk to a family member to see how, the patient is taking treatment or not taking treatment. What are the attitudes within the family towards medications and so on? And is there a support? Is there an alliance with a family member and so on? The prescriber may also benefit from turning to, a substance abuse counselor to see to what extent substance issues are interfering with the efficacy of psychopharmacological treatment. The prescriber may want to turn to the supported employment specialist to see if the medicines are helping or hindering supported employment or education activities. The prescriber would also want to interact with the primary care physician or other individuals involved in medical care, because these medicines have side effects and comorbid issues are quite common. Lifestyle is very, very important, and healthy lifestyle practices are very important, and a teamwork involving a collaboration between the prescriber and the rest of the medical care will be critically important. There are other aspects of care, such as psychotherapy, peer support, and cognitive remediation, all of which are important in successful psychopharmacology within a coordinated care setting. Next slide. The second important thing, as I said, is connection with the patient. There is a very nice book written by Xavier Amador called I Am Not Sick, I Don't Need Help. Many individuals with serious mental illness do not believe they have an illness, and often they stop the medicines once they begin to feel better. How does one address that? And this is a process. This requires alliance building between the prescriber and the patient. And Xavier Amador has outlined this principle called the LEAP principle, where the therapist would listen, empathize, and find a point of agreement. The patient may not agree about the diagnosis. The patient may not agree about the specific treatment that is being prescribed. But the patient and doctor might both agree on a particular problem that both of them will agree with. Maybe the sleep problem, or maybe the weight gain problem, or maybe the problem in concentrating, and so on. And use that kind of a point of agreement as a way of building a partnership. So if a patient says, I can't concentrate in my classes because my mind is cluttered up, and this is why I dropped out of school, that may give an opportunity for the doctor to explore what the patient is really keen on. The patient may want the mind to be quiet. So you find out, what is it that makes the mind so cluttered? And then the patient might describe the hallucinations. And then, the doctor might explain how the brain is cluttered because of a, chemical imbalance, and perhaps explain how dopamine might contribute to this kind of a clutter of the mind. And fine-tuning the dopamine system with a medicine might actually help matters. So psychoeducation, even going to the drawing board and explaining the pathophysiology of the illness, correcting any misinformation, involving family members, using medical models like, high blood pressure or asthma and so forth. Any of those approaches could help in specific situations. Next slide. Comprehensive assessment. Diagnosis is critically important. Not only diagnosis, but also what factors trigger the illness. What medical illnesses might be coexistent or preceding the illness. What are the individual's attitudes towards medications? What have been the medicines that worked best in the past, and what is it that has not worked? What is it that the patient is likely to take and agree and adhere to, and what is it that might lead to a dropout? What are the other medicines that the patient might be taking? Alternative medicines, over-the-counter medicines, and so on. And also get lab results as needed. Your liver function, the kidney function, the glucose, the lipid profile, prolactin levels. It depends on the situation. So a comprehensive assessment is critically important. Next slide. Choosing the right treatment. When the person is in the first psychotic episode, it's important to know what is the medicine to start with. There are 69 antipsychotics, for example. There are about 30 different antidepressants. How does one go about choosing the right medicine? So choose the medicine with the most favorable side effect profile, because most of the antipsychotic drugs work somewhat similarly, with the possible exception of clozapine. And also it's important that we just focus not only on the symptom improvement, but also overall recovery. The general principle in managing individuals, especially when starting a new medicine, is to start with a low dose and go slow, going up, so that you find, as Nate was pointing out, find the minimum effective dose. That's critically important. And also identify side effects, warn the patients about side effects, so that you catch them in the bud and prevent the side effects. Also educate them about the medical issues, medical comorbidities, and prevent any kind of weight gain or other medical comorbidities, hyperlipidemia or diabetes risk and so forth. It's better to prevent rather than to treat.
I'll put in there. I take actually diabetes medication to help prevent I take metformin to help prevent diabetes from developing.
It's a commonly used practice to prevent diabetes and also prevent weight gain by combining with an anti-diabetic medicine like metformin from the get-go. Even though it is not necessarily approved by the FDA for someone who does not have diabetes, many doctors do prescribe, and which is an acceptable practice. And also doing self-ratings by the patients about the severity of their symptoms, what we call measurement-based care, which will help us each visit to decide whether to adjust the dose upwards, downwards, or change, and so forth. And then there is the shared decision-making framework, which we'll talk about in a moment. Next slide. Next slide, please. So there are, as I said, a large number of medicines, but there are, I won't be able to go into details about every one of them, but suffice it to say, there are two types of antipsychotic medicines. There is so-called typical and there are the so-called atypical antipsychotics. The main difference between the typical and atypical antipsychotics is the typical medicines cause what we call extrapyramidal side effects, which is Parkinsonism, akathisia, which is restlessness, or dystonia, and so forth. But the typical antipsychotic drugs like the haloperidol and the fluphenazine and the thiopixine, Navane, and so on, they are, somewhat better when it comes to weight gain and causing metabolic risk. On the other hand, we have the more newer medicines called the atypical antipsychotics, of which the examples are Abilify, aripiprazole, Zyprexa, which is olanzapine, Seroquel, which is quetiapine, Risperidone, which is risperidone, ziprasidone, and durasidone, and so forth. The main advantage of these is that they are less likely to cause extrapyramidal side effects like Parkinson's disease, but some of them have a higher risk of causing weight gain and a risk for diabetes, especially clozapine and olanzapine, and to some extent risperidone and quetiapine. And compared to the typical antipsychotics, atypical antipsychotic drugs are less likely to cause prolactin elevation, but they can also cause some prolactin elevation. Next slide. What does one try first? In the RAISE ETP study, it was recommended that the atypical drugs like risperidone and ziprasidone and Abilify should be considered first. The drugs that are likely to cause weight gain, such as olanzapine, and should be considered next. And typically, first-generation drugs like haloperidol and fluphenazine should be considered later. Even though in practice, haloperidol and fluphenazine are still used quite frequently, they're much less expensive. So if cost is a consideration, first generation drugs can be still worth considering.
I would add, for Haldol, I got an injection of Haldol in a hospitalization, and it was a horrible experience. I had a dystonic reaction walking around the halls. I was having trouble lifting my legs, so I was really lifting my knees far up in front of me. My back was arching involuntarily. My eyes were going back in my head. So I was looking at the
Those are called
ceiling.
dystonias.
Yeah, dystonic reaction. It was really awful.
How many years ago was that, Mitch?
Oh, I don't know, maybe 7 or something like that.
Yeah. So nowadays, for a first episode of psychosis, these drugs like haloperidol are not recommended as a first choice, exactly for the reasons that you described.
Yeah.
Because there are better medicines like Abilify, ziprasidone, and so forth. But
Well, I had with first antipsychotic they had me take was Risperidol, and they had increased that to a dose that I had pretty severe akathisia, which is another side effect that you want to avoid, because feeling that makes it, you don't want to have to endure that.
Very uncomfortable.
It makes it, yes.
Yeah, absolutely. Thanks for bringing that up. Next slide, please. So the dose is important. Often the underdosing is a problem as well as overdose. In the first psychotic episode, usually patients respond to much smaller doses, almost like half the dose of a multi-episode person. So it's good to start low and see what is the right dose that a given patient needs, so that you don't give any more than what is needed. And it's also important to keep the duration of treatment to an adequate duration before thinking that it is not working. So the recommendation is to continue a given medicine for at least about 4 months before considering them as being ineffective. Because most medicines do work over the course of time. Giving it up too early can be a problem. Next slide. Charles brought up the issue of compliance or adherence, which is a significant problem. Almost 80% of individuals with schizophrenia have non-compliance problem, either partial or total non-compliance. And one good solution for that is injectable antipsychotics. There are several of those available now. There are the injectable risperidone, injectable paliperidone, injectable aripiprazole or Abilify, as well as injectable olanzapine. So there is a rich amount of choice that is available, but most commonly nowadays we use injectable paliperidone, which comes as a once a month or once in 2 months or even once in 3 months preparations. I could use this. And there is even a once in 6 months that has just become FDA approved. It's called Invega Hafira. Just you remember it as half a year. But I haven't seen it as much used yet. Next slide.
I think that injectable, long-acting injectable medications are scary because of the side effects. They might have the same side effects as the other antipsychotic medications, and they're designed to last a long time in the person's system who is injected. So if there's a way to test them out before really
so this is why,
long.
Excellent point, Nate. This is why it's important not to start off treatment with a long-acting injectable. Always start with an oral medicine and make sure that there are no major side effects, and then only transition onto the injectable. That's the solution for that. Shared decision making. As I said at the beginning, we may be the expert in the treatment, but we are not the expert in the individual's illness. The patients themselves are the expert, and so we have to listen to what they say and listen to our experience and develop a joint decision making or a collaborative decision making. And again, it is always important to ask the patient what is working and what is not working, and what are the issues for which the patient wants help. What are their priorities versus what we think as the priorities. What we think is that the priorities may not be the priorities for the patients. So we have to get that, right there, those right priorities set up at the very beginning. Next slide. Check and prevent side effects. So early monitoring, early detection of side effects, educating the individual about these side effects. Start slow, go slow, reducing dose if needed, and also consider switching antipsychotics. There are side effect medicines for most of the side effects, like akathisia would benefit from propranolol. Parkinsonian side effects would benefit from benztropine or cogentin, and so forth. So talk to your doctors and you develop a collaborative approach to finding the right side effect medicines. Comorbidities are common. These are listed here: high lipid levels, smoking, then diabetes risk, hypertension, metabolic syndrome. All of these are increased in prevalence in individuals with serious mental illness. And preventing comorbid conditions is critically important, and medications can contribute to comorbidities, and lifestyle education and appropriate use of medicines, the use of low and minimum effective doses would be the way to go. The last C here, which I don't have a slide, is on consult where necessary, because we don't have solutions for everything, and we end up with a limit as to our own knowledge. So when in doubt, always consult. So I think that was my last slide, and there was one more slide I think, Michelle, you had.
Hi all, we have maybe time for 1 or 2 questions. Thank you all for your really thoughtful feedback. Really appreciate description of some of the experiences that you've all had as well, and wealth of knowledge, Dr. Keshavan, that you have in this work and in training residents and new providers for many years. I saw some stuff in the chat related to some book recommendations, some concerns about some of the medications with high levels of side effects. Anyone want to?
Yeah, you mind if I take a stab at that?
Sure.
So thank you for sharing, because listening to your experiences, like, it's really painful, because I see that every single day. Like, my patients come in Parkinsonian and apathetic and in pain. Like, I have a kid who's upstairs right now. Mom, he couldn't close his eyes to sleep for a month. And the parents were convinced it was because he wasn't taking medication. He was on Haldol, Vega, some other bull. And he, like, literally being poisoned. He couldn't close his eyes. And parents are arguing with him because they think he's not medication compliant. And I think that's pretty consistent with the overall level of skill in treating psychosis in the community. People pick medicines because they have some like magical attachment to them, not for any particular reason, right? There's no legitimate reason to prescribe Haldol in 2022 for anything.
Yeah.
But the one thing I was concerned that I felt like, why was clozapine left out of the discussion?
Yeah, so it's an excellent point. Clozapine, it was not a deliberate leaving out of clozapine. Clozapine is not often used in early course of psychosis, even though it should be going forward. I did mention clozapine when I was initially talking about the efficacy of side effects, efficacy of the various antipsychotics. The only antipsychotic that may be superior to the other antipsychotics when others medicines don't work is clozapine.
I would go further and say I do tons of, that's pretty much what I do. I work for a state acute care facility. Yeah. So we make a point of it. That book recommendation I put out there, it's unfortunate because people are denied the opportunity to get this really life-saving treatment, and it's not brought up because doctors don't know how to talk about it, doctors don't prescribe it. And I do think there's a lot of people suffering with Parkinsonism and akathisia who could be feeling better, but it's just not available to them.
Absolutely.
I actually take clozapine, and I mean, the things you mentioned, I mean, I do have side effects, but you mentioned like the Parkinsonism and it's pretty good for those things. It's not, I'm not experiencing like akathisia or.
Yeah. And when people say side effects, the other thing I noticed is that sometimes, especially when people are in the most severe psychosis, they have a hard time describing what their perceptual disturbances are.
Yep.
So you might be hearing about side effects, but it might sound like, don't reduce what they're saying to just delusions or hallucinations, because it could be really real perceptions that are painful.
Absolutely.
And have like sound really weird the way they're saying it. I see that mistake all the time.
Yeah, one thing about clozapine is about 30% of people with schizophrenia have treatment-resistant schizophrenia, but it takes time to establish that. But from what I've heard, and I'm not a prescriber, clozapine would probably be the first choice for treatment-resistant schizophrenia.
Absolutely. But it's also important to remember that only about 1/3 of those who have treatment-resistant schizophrenia respond to clozapine, maybe about a half.
Yeah.
There are individuals who do not respond to clozapine either. And often it has to be a combination of clozapine with another medicine or maybe ECT. So,
ECT, they have the number needed to treat as low as 3. So in our hospital, because it's pretty much the bulk of our cases are folks who are really still suffering despite being on clozapine, ECT. And unfortunately, these days you have to ration it because there's so few providers. And you have to get people out. I was wondering, I was reading a book the other day. It was from a patient wrote it. Do you guys find that 10 to 12 hours of sleep is about right? Like, are we not? Because when patients on the inpatient unit, we're waking them up at 6 a.m. Sometimes it feels like you said you should work with their circadian rhythm. Do you think that that's been a problem you've noticed when you've been treating? Like people expect things are impossible, like waking up at 6 a.m. when you're on clozapine kind of thing?
Yeah, I used to be that way. Like I would stay up to like 4 a.m. watching Conan O'Brien or something, and then not be able to get up and be productive during the day. So doing the meds with the circadian rhythm helps.
Thank you both. I really appreciate you guys coming on talk. Thank you.
yeah,
Thanks so
Michelle
much.
asked the question whether we can stay. Unfortunately, I have another meeting at 3. I have to go, but this was a very, very helpful discussion. I learned a lot as well from all of you. Thank you, Nate, and continue. Please feel free to continue with me there. Yeah, thank you.
Thank you so much. And I recognize folks may need to go. I'll make a really quick plea. If Nate and Charles, if you're on, want to stay on for a couple more minutes to answer questions, we can definitely do that. We do have one more of this series coming up on August 11th on supported employment. And so look out for the information about registering for that if you're interested. And if anyone's interested in viewing the recording for this webinar or any of the previous ones in the series, this is the link that you can find that recording. You'll get a copy of this to the email that you registered with as well. So thank you.
Thank you all so much for attending today's webinar. I'll be posting a link to an evaluation form in the chat, and you'll also be receiving the form in email right after this event. And we also, as Michelle mentioned, have a few upcoming events, so feel free to register for those on the Mhtdc website. And I just pasted the evaluation link in the chat.
Thank you very much. I feel like there's much more we could discuss about this topic. One of the biggest pieces I'm hearing is when we think about joining a new coordinated specialty care team and understanding what medication management is all about, I think it's so important. And I think maybe one of the biggest misconceptions or something that I'm really reflecting on for myself is this idea that medicine is just helpful and kind of discounting the experience of side effects. And I think Nate and Charles, and you're describing some of this, I think that you really today really underscore this for me in a way of how painful that experience can be. And when we're, kind of in my role as a psychologist, working with folks who may experience psychosis symptoms, I'm often trying to convince people to try these medicines out because they can help with thinking and help, to make, a meaningful, valuable life when symptoms are getting in the way of that. And, I think like you said, there's no perfect medication out there. And so it's so tricky, all of these choices.
Yeah, some side effects might be more manageable than others.
There was one last question in the chat that I saw from Mikkel asking, any thoughts on, are there any advantages for injectables beyond adherence? I don't know if Charles or Nate, you have any thoughts on that.
I think injectables are scary because I mean, these medications can have really pretty bad side effects, and an injectable is a long-acting version of that. I mean, they already have long half-lives. Like if you started feeling a side effect from something you take orally, if you were to stop taking it right away, it'd still take a little bit of time for that to get out of your system, because the half-life is pretty long for most of them.
Yeah.
Um, So to me, the injectable ones, I mean, I think if the medication is one that can be tolerated, then I think it could be a great thing, because you know, if it's known that the person's going to be able to tolerate it, and then they don't have to worry about like taking the medication, sure, that could be good. But I don't know, my experience with side effects makes me feel like it's not, it makes me feel that those medications are kind of scary.
I feel like they're doing it for the wrong reason, maybe more like kind of to enforce something upon you rather than to make medication more manageable in your life with the injection.
Yeah, I mean, I think sometimes it might be like a tendency to try to make the person getting treated more convenient or something like that, you know, like so maybe not necessarily like the best thing for that person. Might be some people might prescribe it to make their life easier, but not necessarily I don't think it's necessarily doing what's best for the person who has to take the medication.
Yeah, what I would add, if anyone might be interested, here in Watertown, Mass, there's this startup called Linger Therapeutics, and they're working on a long-acting pill. If I remember correctly, it's 2 weeks of risperidol, but it hasn't been FDA approved yet. That might be a compromise between regular daily pill and long-acting injectables.
Makes sense. One of the things for people that I know who take long-acting, and it's worked well, I think just like you said, Nate, like first they take the pill version to make sure it agrees with them.
Yeah.
And then once they get on the long-acting, one of the advantages has been just not having to think about it every day, not having to make a choice every day to remember, like they can go, you know, go overnight hanging out with their friends without needing to remember to bring their medication, you know, stuff like that, that's, you know, a bit of an advantage. But
my prescriber told me that with especially young men with substance abuse issues who might forget to take their meds, that he tries to encourage them to take a long-acting injectable, and that tends to work well.
So, sorry, I want to say one more thing, and then I realize we do have to stop, even though I feel like we're not done. So maybe we'll plan on medication management or thoughts on medication part 2 in the future. Any final words of wisdom, Nate and Charles?
I was going to mention, since ECT came up, I mean, they can help people get out of an acute phase of psychosis, and it can also help treat some of the side effects of like depression and anhedonia and things like that. And I guess it's not like in One Flew Over the Cuckoo's Nest. It's more like go in and you know, put anesthesia in you and fall asleep, and the next thing that I know after that is I'm waking up. So it's not a terrible experience.
The first one's a little more uncomfortable, first couple times.
I don't know if the first few are
It
more
sounds like
uncomfortable.
you're,
But
yeah.
I mean, it's kind of not a lot to remember about it. I mean, I go in and they put the anesthesia in, and then I'm asleep,
Hmm.
and then I do the treatment. So
And when ECT works, sometimes it can really work. I've seen people just experience relief, especially from depression.
yeah.
Sometimes, yeah. Charles, any last words of wisdom for us?
Be aware of negative and cognitive symptoms. And Roscoe Brady, a doctor at Beth Israel and McLean, is studying brain stimulation for negative symptoms.
Mm.
But I don't know if anyone can recommend that yet. Like,
Mhm.
he's doing it as research. I don't know if the FDA or some other agency has to approve it.
Oh yeah, that's an area of research called transcranial magnetic stimulation, which is from what I understand of it, is a possible alternative to ECT that may be just a little bit easier to administer, doesn't require anesthesia in the same way. Is that fair for folks to know about it? Well, thank you so much for all of you, your active participation and your questions, and Nate and Charles for your generosity and sharing your experiences and your stories. I think we're going to learn, folks, for years to come, we're going to learn a lot from what you've shared today as we put pieces of this into the upcoming course. So I hope you all have a good rest of your day, and
Yeah,
look
too.
forward to hopefully seeing folks next month. Bye.
That